Standard cardiac rehabilitation for folks with coronary disease and for patients with heart failure is a series of, it's a 12-week process, 36 sessions, 3 sessions a week, and they start off going from, supervised, slow walking, moving, and with some guided exercises, kind of strengthening activities, and they progress as far as a patient really can progress to kind of continuous mobile aerobic activity. So none of this high intensity exercise, which may be a future process, but this is really continuous kind of aerobic activity, things that really are going to help our patients get along in their activities of daily living. We want them strong enough to kind of bend over, pick up a carton of milk, go to the kitchen, prepare their food, get dressed, walk around the grocery store. So really more focused on that. I don't think right off the bat there are some transition centers. Many of these places you can continue to go. At Duke, we have cardiac rehabilitation. It's about a mile down the street from Duke, and folks will get a membership and they can continue to come. But again, that's not necessarily going to be covered from your health insurance. Maybe it should be, or from Medicare. But typically we give a reduced rate and we can negotiate with folks to make it somewhat affordable. But the goal is really to give them the tools, the teaching. There's dietary teaching, how to eat, how to weigh yourself, how to exercise, what are the things about life. So it's kind of like going to school and getting a degree. I mean, it's sort of a diploma if you graduate at the end. But I agree, there is room for more. Great, there's many other papers that are really starting to look at this, like who has access to cardiac rehabilitation. So I think at Duke, if you come in as an inpatient to one of our, we have a Duke in Raleigh, we have Duke Regional, we have Duke University. Say you go to, like I said, NYU, or you go to a local community hospital, or Wake Med for us in Raleigh. They we can refer you to anywhere. So what you try to do, you try to find the cardiac rehabilitation facilities that are nearby. But again, you're right, they have to have an infrastructure there. There are some in some small towns, but if they don't have an exercise therapist, physiologist there to kind of move someone through, there's some limitations there. I think beyond the scope of this, but we get into this a little bit in the paper, is that, we need to expand coverage, and we may need to move to things being more remote monitored, et cetera. In cardiac rehab, you almost always have an MD there, or DO, so a physician supervising this. Oftentimes it's a cardiologist. At Duke, in our cardiac rehab, we have someone on site we have 2 sessions a day. In the morning, it's actually cardiac rehabilitation, and then in the afternoon, it's like pulmonary rehabilitation. So there's an MD covering. Typically, you can do that by having someone seeing patients in clinic, but it's very rigorous. You have an intake exam and outtake. There's some prescriptions that are going on. There's coaching going on. I actually happen to cover from time to time for an hour or two if a faculty member has something. And we have 3 to 4 exercise physiologists going over things with patients. We have a physical therapist. There's an MD on site, kind of walking around. So you want to it's a community. Instead of going to a gym with just very heavy lifters that are very strong, this is about a lifestyle. So people are learning how to work out together. In terms of, like you said, physical therapy, it's a team-based approach. I'm not saying you always have to have an MD, but that's typically how things are structured now. Again, when you graduate and move forward and you have the stamp that you're allowed to process otherwise, I think the environment can be totally different. It could be electronic, it could be digital, it could be supervised in another gym. I think the final message is we've shown that, hey, I think this is a great new step. We have a new intervention that's approved and funded for our patients with heart failure with reduced ejection fraction. But like most studies, we leave with another question. We have patients that are still ineligible for cardiac rehab. There are small studies, even a small meta-analysis, but it still only gets to a couple of hundred people in patients with preserved ejection fraction. They tend to show benefit. If you look at the guidelines, it actually doesn't specify whether patients have reduced ejection fraction or preserved ejection fraction. It says if you have chronic heart failure, that you should actually undergo cardiac rehabilitation and exercise training. So I think in our body of literature, we support that and recommend that, but it's not being covered yet. So I'm still going to recommend that for my patients with all types of heart failure when they're stable on optimized medical therapy in a graduated stepwise form. But unfortunately, they don't necessarily get CMS coverage for that group. So I think we need more studies to understand these patients that are still ineligible. And then I think secondly, I think we need to learn how to transition cardiac rehabilitation into a more digital, on-the-move age with biometric data, tracking. There's a whole new world of technology to kind of get access to our patients. But we need to learn how to do it methodically and safely, so it's a great therapy for them.